I want to welcome you all. I hope you can see my camera or photograph in the corner of the slide, and I'm hoping you can see my slide. So we'll pick up where we left off the last time, and just to remind those who are new to this seminar, it's an interactive seminar. I typically show a case, a scanned slides case with the history. I show you the morphological features, and then I would anticipate that you'd give me your thoughts and your differential diagnoses in the chat, which I will continue to monitor and then answer directly to you. That's the way it works. And let's see, I've got about five or six cases for you today. Let's see how these go. For those of you who were here the last time, would recall this was a case I put up but did not complete, left you to think about it. And this was a segment of an aorta that was removed for mucoid degeneration or aneurysmal dilatation. But this is the aorta. Let's just go high power, and just to orientate you, right? Advent tissue on the outside, some fat and fibrous tissue, intimal surface on the inside. That's the lumen where the arrow is, and then the rest of it is media. And just to show you some mild metachromatic or mucoid degeneration, which this shows. I don't remember whether the patient had a dissecting aneurysm or not, but that was seems to be some sort of dissection there, but that was not the reason the case was sent from our sister hospital. The reason it was sent was because of this. Here, there's the adventitia. Okay. And in the adventitia, you can see these nests and structures here, just to show you the morphology here, and these cells as well. So there were a few suggestions the last time, and I remember some people did put in some suggestion. I'm hoping that you would have thoughts again. Just to remind you, we're on the adventitia of an aorta that was removed for a dissecting aneurysm due to mucoid degeneration of the media, and the reason it was sent through to my bench was because of these structures in the adventitia. The question was, what are these? So this is a question I'm posing to you. I can go on higher power. All right, let me just go and check if the chat is okay. Yeah, we've got it. Albert Tool, hello, just wondering if it started yes, we did start. Okay, we have started. Hopefully you're back on time there. Any thoughts on what these are? Some of them look, they look very bland. I will share that with you. Nuclei look fairly uniform. It's a little distorted. Don't be fooled by that. And these cells here, it's sort of loosely cohesed, also uniform looking. And between here you have those cells, pink, and these cells also sort of pinkish, but more sort of cuboidal-like. Don't take cuboidal as being epithelial. I'm just giving you that for a description, cuboidal-like. And right next to it, you also have these single cells here, these plump pink cells, little clusters of them. Okay, these pink larger cells look different from these smaller cuboidal-like cells. I will share that with you. And even within these, you may have some of these plumper pink cells as well. Any thoughts? Okay, paraganglion cells. Okay, paraganglia are usually a much more abundant cytoplasm, large nucleus, prominent nucleolus, and those can occur at this site. If you wanted to do stains for that, you could go ahead and show that they're all negative for paraganglion cells. That was Premila. Sheena, hemoangioendothelioma, looks vascular in origin. I can understand why you said that, because some of these look sort of vascular-like or vasoformative. They seem to have lumina. I did not want to use the word gland-like, That would be another descriptor, gland-like. And then Gerson saying a cytokeratin stain may be helpful. So Sheena, these are not vessels. I did not do stains for vessels, but they're not vessels. When I reveal to you what they are, you'd understand why I did not do vessels. You want a CD34, CD31, yeah. For discussion purposes, let's say that that's negative. The Gerson suggests a cytokeratin stain. That's very useful because these gland-like structures are cytokeratin positive, diffusely cytokeratin positive. And Omar is suggesting, as well as Priti, mesothelial. So mesothelial markers are positive in these gland-like structures. They're positive for, you know the mesothelial markers, okay? I cannot remember which ones were positive, but certainly calretinin was positive. And I don't remember whether D240 and WT1 and CK56 were positive, but there were at least two markers positive. So I was very happy that these were mesothelial cells. Gland-like structures may be metastatic adenocarcinoma. And that, Tiba, is the real reason why I'm showing you this case, because that's always a suspicion for whether these are carcinoma. In fact, as a sidebar, let's look at the adenomatoid tumor that you see in the uterus or paratesticular distribution. Those form little glands, and those can be misdiagnosed as metastatic adenocarcinoma. So I suppose you could do the same thing here. And understanding and knowing this lesion as well as those adenomatoid tumors that we see in the lower pelvis is also useful, because once you recognize one and you do the stains, you would recognize that all the time. Okay, so Jan, epithelioid mesothelioma, so that's giving it a neoplastic characteristic. This, let me just go back to the low power of this. This is not expansive. This is just these cells hanging out in the adventitia, forming these gland-like spaces. Here, just lining the serosa, those pink larger cells, which, like I was saying, you could see them in the stroma as well. Here's these pink larger cells as well. So these have a different lineage. Those are not mesothelial. Omar calretinin, correct? Yeah, that was positive. But the idea is not to call it metastatic adenocarcinoma. These larger pink cells stain up with histiocytic markers. Okay, so take your choice, your pick. You may like CD68 or CD163. There's a new marker which you may or may not have, IBA1. I think it is IBA1 or IB1A. I think it's IB1A. It's very useful markers. Our hematopathology team has it, and I use it because it has a very clean background, which is very useful in distinguishing the background cells. So you can take your pick on which of those you have. Now, putting this together, we have mesothelial cells here. So these are mesothelial gland-like structures. Okay, those are mesothelial cells. And then we have histiocytes. This was first described by Dr. Rosai, late Dr. Rosai, in about, I think it was probably the 80s, where he described these in intracardiac mice. He called them intracardiac mice. So these were excrescences on the heart valves that existed with mesothelial cells and histiocyte cells. And he called them, so M's for mesothelial or monocytic mesothelial, because monocytes are histiocytes as well. Intra-I, C cardiac, E excrescent. So he called them mice. If you Google mice, you'll get the full picture. This is extracardiac, obviously, and they've been described outside of the heart as well. And I'm really, truly appreciative of your differentials and your contributions, because recognizing these is useful. I've probably seen maybe 2-3 outside the heart and maybe 2-3 inside the heart. And all you have to do and resort to are your mesothelial markers and your histiocyte markers. All of these here were histiocytic. These are all histiocytic. Not too much. Maybe here's some clusters there as well. I think it's probably just a reactive phenomenon. I don't have any explanation. And I cannot remember what Dr. Rosai offered as an etiological factor in these. His description was intracardiac and associated with the valves, and had some fibrinous exudate as well. So just mice, keep that in mind. Something that you may encounter, and not to call it any of these concerning neoplasias that we talked about. Thank you, Jan. Yeah, for those. So if you Google it, that should come up. Just a nice sort of odd lesion that we see, but that can even if you did the vascular markers, they'd be negative. And if you did the epithelial markers, only keratin was positive, but they look so bland. And just think of the adenomatoid tumor, uterus or paratesticular. It's a similar type of morphologies, except the adenomatoid tumor is regarded as a neoplasm. These are not. These are just hanging on loosely aggregated in here in the serosa, and you can see that around heart valves with some fibrinous exudate. I saw one probably a few months ago, also from the cardiac team, which was a nice example of that. Okay, any questions or comments on that? Solomon, unstable network. What is the answer, please? I'm going to defer to Ava Solomon to help you with that. I must confess I'm computer illiterate, and I'm just so grateful that this system is working with scanned slides and being able to communicate with you all. So, all right, let's move on to another case. That's 6392. This is a neoplasm. Here you go, 6392. So the history here is a 41 male, and this is a scrotal mass. I actually got this slide from a colleague of mine who was in dermatopathology. He showed it to me a year or two ago. What's this, 23? So 2 years ago. And here, I'm just going to share it with you. So here you go, epidermis, scrotal mass. Remember, it's in the scrotal skin. Here's the epidermis. And that there is where this neoplasm is. Let's go down and look at it here. It's better seen here. Cells are, forming sheets, I would say. There's some collagen in between, or it's infiltrating collagen. But here is probably the best decent representative of what the morphology is. Large cells, large nuclei, prominent nucleoli, and cytoplasm being palely eosinophilic, fairly abundant. Not too different from what we just saw in the histiocytes in the serosa. They look pretty similar to that. But that's just a comment. I'm not saying these are histiocytes. They're not histiocytes. If you want to do the histiocyte marker, you can. That would be understandable given the histiocytoid morphology of these. All right. And here you can see these nuclei. This one's probably binucleated, varying size and shape. Some of them do have some dark chromatin, but others have just finely vesicular. Here's another. These are all tumor cells. I'm just pointing out to ones. This looks a little pinkish. All right. Any thoughts? Any thoughts so far? So we have a scrotal mass in a 41-year-old. This was a punch biopsy of his scrotal mass. And this tumor is lying in the dermis of this skin biopsy. Yeah, just to give you a better impression of these. Yeah, this is much better as well. I guess you can also, they sort of sheets and cords, no particular pattern, sort of strand-like in parts as well. And I'm just going to look to see if there are any other features here whilst you ponder over that. No, there's, much of it is sort of invading the dermis, but there is some collagen as well. There is some collagen being produced here. I don't think this is normal collagen. I think this is all as a result of the tumor, sort of almost hyalinized type matrix. But let's go back to the tumor cell, the morphology. I just want to hear how you would investigate this in the scrotum of a Right. Okay, we're getting some very good comments. Albertul's online, so that's good. Reminiscent of mammary type myofibroblastoma with the collagen bundles. I hear you, and that's a very good thought. Remember that you can get the mammary type myofibroblastomas, extra mammary myofibroblastomas in that area as well, in men as well. He's a man, yeah, he's 41 and he's a male, so you can get that. So thinking about that, uh, CD34 Jasmine stains that will help you in that. And then, of course, uh, RB1, which is lost if you have RB1 retinoblastoma gene. Remember, that's also lost in things like spindle cell lipoma as well as cellular angiofibroma. So that's a good thought. The other stain I like to do for mammary myofibroblastoma, mammary type myofibroblastoma, is an ER, and that's useful. I find that useful. Albert Tool also asked the question: Are these cells rhabdoid? That's a very good thought, very good observation. Let's hold that and let's see what. No RBCs. Not sure what a bite cell is. You have to explain what that means, Solomon. Bite cell, but epithelioid hemangioendothelioma rule out myofibroblastoma. So if you thought epithelioid hemangioendothelioma, and if you did do a vascular marker, the CD31 would be negative, but the CD34 is positive. Now I'm giving you the markers because you mentioned vascular. ERG is also positive, okay? And I'm not being sort of surreptitious. I'm just giving it to you as you're requesting it. And so you've got CD31 negative, but you've got CD34 positive and ERG positive in this tumor. And ERG was positive in this tumor. So I like that. EHE versus myofibroblastoma seems like some type of lower genital tract tumor. And we know epithelial, well, we went there, we gave you 31, CD31 and ERG being I beg your pardon, let me say it, CD34 positive and ERG positive, but CD31 negative. Cellular fibrous histiocytoma. Yeah, that's a good thought. That's a very good thought. Let me just go back on low power and see what the relationship of this infiltrate is to the dermis. Uh, Remember, typically in the dermatofibromas, you get a hyperplastic epidermis, and I can see why that came to mind. Uh, there's no specific marker for the dermatofibroma or cellular fibrous histiocytoma or cellular variant of dermatofibroma. Factor 13 is one of those markers that people use, not very specific, but does work pretty decently. It's more a rule out other things, right? Rule out other things when you're considering that. And then, of course, the morphology is very useful there as well. Does patient have history of HIV? Omar, what do you think of Kaposi sarcoma? We'll give you the HHV. Is negative. Albert Tool, rhabdomyosarcoma. You mentioned earlier, Albert Tool, are these cells rhabdoid? So let's come back to that. You've got CD34 positive. Okay. Let's leave the ERG out for now. Not confuse the picture. Right? Is there anything else that you'd want with your notion and your morphological interpretation of are these cells rhabdoid? Muscle markers are negative. Let's get that out of the way. So skeletal muscle, MyoD1, myogenin negative, Desmond negative. Abundant collagen between tumor cells, focal rhabdoid morphology. Yes, correct. There is rhabdoid morphology. Correct. Omar, YE, I don't understand that. MyoD1 is negative, so rhabdomyosarcoma, skeletal muscle markers are negative. Cytokeratin, EMA, Vimentin. I don't do Vimentin, Albert, too. I'm sorry. I the only time I'll do a Vimentin if I've done 30 stains and none of them are working, I'll do a Vimentin to check if the immunogenicity is intact. Otherwise, I don't use Vimentin at all. In the old days when I used to do GYN, I used to use GYN pathology, I used to use Vimentin to distinguish between cervical and endometrial adenocarcinomas. That was useful there, but otherwise I don't. Albert Tool, cytokeratin is positive and EMA is positive. So there you go. You've got EMA pos, you've got cytokeratin pos, you've got CD34 pos. And I said I don't read it. Yes, good for you. There we go, Janet. Yes, epithelioid sarcoma, INI1. So that's a SMARC B1 that you want, and that is lost. So it's INI deficient now. This is an epithelioid sarcoma. There's a full house, meaning all the markers are paused. But if you go back to the literature, about 8-10 years ago, Dr. Marko Mietznen from NIH, now then Armed Forces, wrote a paper showing that 60% of epithelioid sarcomas are ERG positive. So that was the reason I gave it to you. So I apologize for the confusion, but you were asked for that and I had to give it to you. So be careful of that, because if you're thinking vascular and you do CD34, 31, and ERG, you probably get two of them positive as well. So just something to be wary of. INI1, of course, is the key factor in this. But again, because of the epithelioid morphology, you may ask yourself, is this epithelial? And doing the cytokeratin and EMA, both of them would be positive as well. But CD34 is useful to rule out carcinoma, because CD34, in just my own personal experience, is hardly ever positive in carcinomas, meaning that they're negative in most of carcinomas. So it's kind of, for me, useful seeing a CD34 pause. Then I know it's not a carcinoma, and I know it's not epithelial. There is one that's positive, which is the nut carcinoma. So if you have others, you can share with us. But the CD34 is usually so. Keratin, EMA, CD34 helps you rule out carcinoma, and then thinking about the rhabdoid cells fitting in nicely with epithelioid sarcoma. So the location, of course, of this is more sort of proximal. But when you read the original paper by Dr. Fletcher, I think it goes back 98, 99, AJSP, the first author is that nice man from Switzerland. It's on the border of Switzerland and France. I forget his name now. But anyway, when you read that paper, or even if you look at the pictures, you'll see that there are lots and lots of pink cells, large pink cells around large areas of necrosis. So the morphology is really atypical for classic or conventional epithelioid sarcoma. This seems to be more sort of conventional in its morphology, 41-year-old scrotum. So I think you'd probably have to work through it with stains in order to figure this one out. But you guys are smart. You got it out. So that's good. So epithelioid sarcoma, high grade, as you know, and in coming in two sort of morphological and location sites, the extremities, hands, fingers, and then of course the proximal variety. I've seen more proximal varieties in women around the vulva than in men, but here's one here in the scrotum. So just a nice example. Any questions or comments? Collagen, yeah, the collagen. If Albert 2, there is an old name that people used to use for this. It was sort of sclerosing as well. So you can get the sclerosis in it as well. And that has been described, this sort of hyalinizing sclerosis in epithelioid sarcoma. It does throw you, but again, just working through your immunohistochemistry, you'd come to this conclusion, I'm sure. Okay. Okay. Let's go then to another case. And the next one I have for you is 10721. 10721. Oh, really? I don't find it here. Oh, there's it here. Sorry. My bad. Okay, here we go. Cause. You got cause. 57 female. And this is a shoulder mass, right shoulder. It's a soft tissue mass. Okay, so we can start with any core. Let's start with this one here. This looks like a tadpole or a puff adder. Okay, so cellular, spindle cells. Okay, and let me give you a medium power so you get a feel for the core before I go down on high power, just a feel for it. Okay. All right. I think they all pretty much look similar, so we could use that as our high power core, or even that. But this is okay as well. Looks pretty decently well preserved. So let's look at this on high power, and you can get a sense of these spindle cells, and get a sense of the morphology. Here's a higher power, and I'm just going to scroll down or scroll up this needle core as you ponder over the differentials and what stains you would like. This I think is a vessel here. Okay, just showing you a higher here, and there's another vessel here as well. And then again, you get a better look of the nuclear morphology here too. Okay, I'm moving along. Let me see if there's anybody who's asking anything. No, nobody's asked for anything so far. Okay. Okay, these areas look a little less cellular than those areas. You can see that. I think these are vessels. I don't. Some of it may be that may be collagen, like the last case. But here you can see fine strands of collagen. Here you can see nothing hyalinized like the last one. But this does have a sclerosing component, fibrosing sclerosing component. This is a high power in these areas. Let's see how everybody is doing. How's everybody doing? Vaguely herringbone, Andy. Sorry, where's the site? Yan. Site is right shoulder, 57 female. Mixoid background, Omar. Correct. And I did not want to say that, Omar, because I wanted you to pick that up. Vaguely herring, neural. All right. Niam. I hope I'm pronouncing that correctly. Neural is a very good thought, and I'll give you the S100 and SOX 10 because that's sort of the basic screening tools. Those are both negative, so let's get the neural out of the way. Albert Tool is thinking exoskeletal myxoid chondrosarcoma. That's a very good thought, particularly in this area here. And I'm just going to go back onto my slide screen, and you can see that there's a lot of myxoid material here. Some people like to use these sort of lacy form pattern like you're seeing here, and some people also like to say that these cells are holding hands, right? These cytoplasms holding hands. So that's not a bad thought at all, So for that, there are no immunomarkers for that, as you know. In the old days, when I was you guys' age, they used to say that 20% of these were S100 positive, but they don't anymore. Nobody talks about that anymore. And people, to make that diagnosis, resort to FISH. Importantly, you do have to rule out the differential diagnosis, and the big differential diagnosis in this location would be a soft tissue myepithelioma because of the myxoid and sclerosing areas. This is nice myxoid matrix because it has that gray-blue material in it as well. So the only way really to rule in or rule out exoskeletal myxoid chondrosarcoma is to do the FISH analysis for NR483, which fuses with either EWSR1 in about 70%, and then another gene known as TAF15. So we have NR483, so that's useful in this. I did do that Albert tool. It was negative. So I got that out of the way for you. Cells reaching out to hold hands. Yeah, that's chondromyxoid fibroma TIBA. That's a good thought. They occur in bone, and they can form a surface mass as well. They can break through flat bone. You may argue shoulder, scapula. What's the radiology? Could this be a chondromyxoid fibroma? That's a very good thought. Again, no markers for it, but there is a. Let me see. I hope I'm not. There is a fish analysis for chondromyxoid, which is a GREM, GREM, is fused in that. I hardly ever use it because I use radiology and morphology. So useful. Typically around the myxoid areas, you get this hypercellular areas. You might even get some osteoclast-like giant cells. So good thought, but this has no relationship to bone. But I admire your morphological interpretation. Okay, Omar, between myxoid liposarcoma, but I don't see any chicken. Yeah, there's no chicken wire pattern. That's a good observation. There's no chicken wire, which is important for myxoid liposarcoma. I showed you two vessels here as we went by. Look at these elongated vessels here, right? Elongated, long elongated vessels. Again, I'm not using the descriptor to give you any. This vessel is also very useful for morphology. But again, it's a little too cellular for just a low-grade myxoid liposarcoma, and there's quite a bit of sclerosis as well. But importantly, like you pointed out, there's no chicken wire vascularity. So let's go back to the chat group there. Myxohyline background. Yeah, it does have a myxohyline background. Okay, we'll keep the myxohyline background, Solomon. Variables, yes, they do. And there's no mitoses. I mean, I did not see any mitoses. So NR4A3 albertul is negative. Myxofibrosarcoma low grade. That's a very good. Sorry. There's two answers. Solomon, myxofibrosarcoma. Now, myxofibrosarcoma, yes, would be differential, but there's no atypia here, right? And if you think about a myxoma, intramuscular myxoma, which is literally low cellularity, hypocellularity, is very, very bland. And as it increases in cellularity, you get what's known as a cellular myxoma. Some people use that term. Those would come in. This is too cellular for either of those. And then if you see atypia in a cellular myxoma, then you're asking yourself, is this a low-grade myxofibrosarcoma? There's no atypia in this, and I showed you the low power. There's no atypia. But here, your second differential is an absolutely correct one, the low-grade fibromyxoid sarcoma. And if you don't have a MUC4, which is useful for screening these and confirming it, that would be very useful in this, and MUC4 is positive. So, like I always say when I come out to Africa and teach, we do have the luxury in our department just here of having a full fish analysis, and so we do have the ability to apply fish and FUS, as you know, which is on chromosome 16, was rearranged. So that rearranges with 7 and 16 in low-grade fibromyxoid sarcoma. That's CREB3L2, CREB3L2. So that's the fusion for low-grade fibromyxoid sarcoma, and that's what this is. Now let's go back to morphology. And yes, I did all of those stains. I did, like I said, I also did the NR483, but I did the FUS as well. And then, of course, I did the MUC4, which came back the next day, showing me that it was diffusely positive, cytoplasmic diffusely positive. Now, the reason I showed that vessel actually paused there, I realized this would fit very nicely for the so-called arcades of vessels. The soft tissue experts like to use descriptors for their vessels. And this was described, I think it was Fulp, in Andrew Fulp's one of his early papers, describing this as arcades. This was first described by Dr. Harry Evans, remember, in late 80s, 87, 89. And the reason he found these was that he was getting referrals or consults of metastasis in the lung, which looked very bland, very myxoid, and very hypocellular. And when he looked at the primary tumors and put the two together, he called them low-grade fibromyxoid sarcoma. Remember, then there was no MUC4, no fusion genes, and no fish to help you. But these arcades were described. The other aspect that was described was this periarteriolar sclerosis, so smaller vessel with sclerosis around it. So it does have, some good morphological features. Like I was pointing out here, there is sort of very focal hyalinizing sclerosis, but I typically don't associate hyalinizing sclerosis with this low-grade fibromyxoid sarcoma. That's why I didn't want to use that term. Okay. So any questions, comments? I've got to go back to the chat here. Low-grade, yes, that's what it is. So I'm glad you mentioned curvilinear vessels, Jan, because curvilinear would be the same sort of arcade that you see, except it has a snake-like appearance. That's where the curvilinear comes in, and that we use that to describe the vessels in myxofibrosarcoma. So, if you were writing this up, your morphological microscopic description, you'd use with scattered arcades of vessels. You wouldn't use curvilinear vessels. All right, Irene, yeah, that would have curvilinear vessels. SFT, well, we didn't even go in there, but that was my initial primary immunohistochemical investigation, CD34 and the STAT6. But I did a MUC4 as well. Ischemic fasciitis, yeah, some of these can look fasciitis-like, but remember that ischemic fasciitis typically occurs in sites of pressure-related, like the sacrum. I guess the shoulder could be pressure-related if patient was bedridden and not turned often enough. You could get that on the shoulder. But ischemic fasciitis has a sort of zoning phenomenon. You get these areas of myxoid areas, vascularity, with parallel granulation type, and then this fibroblasts which have atypia. How do I remember that? Is because when you read the first paper by Sharon Weiss in AJSP, she called them atypical decubital fibroplasia. Atypical because you get atypia. Okay, you can call them degenerative or reactive atypia. Decubital because they occur in these pressure sites, sacrum, and fibroplasia because it's not neoplastic. Now we call them ischemic fasciitis, and you all recognize it. But those are the features. This no atypia doesn't have that vascularity of ischemic fasciitis. It usually has nice parallel orientation as well. So, good thought. I like that thought. Just for discussion purposes. And ischemic fasciitis is really a morphological diagnosis. You may do some stains to rule out things like, low-grade fibromyxoid sarcoma and SFT, myxoid SFT, that sort of a thing. But ultimately, it's a morphological diagnosis, clinical, radiological. Remember, the surgeon will say sarcoma because they're taking out this big mass of tissue, in a patient who's who's been bedridden for a long while. Those are the classic pictures of that. Albert tool, collagen rosettes, common to see. That's about 40%. And again, if you go back to, so what happened? Yeah, this is it's a little story, Albert tool. Okay, so late 80s, Dr. Harry Evans, MD Anderson describes these series, very small series, 8 or 10 cases, gives it a name, and then early 90s, Dr. Fletcher reiterates this, these do exist and well recognized. And again, still no MUC4, no fusion gene, right? These are all pure morphologists. And I keep repeating this to our younger pathologists because they did not have immunohistochemistry in those days. It was all pure morphology. We had histochemical stains, things like collagen stains and silver stains, but none of the immunohistochemical markers. So MUC4 did not come on yet. So coming back to our story, so late 80s, Harry Evans described it. Sort of 93, 94, Dr. Fletcher has a series and confirms this entity, because that's important. You always want to know that other experts are seeing the same thing and confirming that these are real entities, and then they enter the WHO as a distinct entity and not a variant of something else. And then come the early 2000s, and this is where Dr. Thorpe and Dr. Weiss, Sharon Weiss's, they had about 33 or 40 cases. They had a good chunk of their series. And in that, this is where Albert Toole's question comes in. These giant rosettes come in. And what they called it, that's interesting, they called it a hyalinizing giant cell rosette spindle cell neoplasm. I'm paraphrasing it. I really cannot remember the full title of that paper. But if you went Fulp and giant collagen rosettes, that paper will come up, I guarantee you, around 2005, 2006. And then subsequently it became realized that and low-grade fibromyxoid sarcoma are one and the same thing. So to answer Albert Toole's question after that long story, it wasn't too long, is that about 40% have them. You know, you'll only see it in resection specimens. You're not going to see it in a biopsy, but you can look for it. Now, did I ever use that as a diagnosis? Yes. In the 90s and early 2000s, I used to look for that because that helped me make this diagnosis with some degree of, confidence. So collagen rosettes is useful, right? So giant collagen, they were large, giant collagen rosettes. They're not these small sort of rheumatoid or granuloma annulare type. It's 3-4 times that size. So if you keep looking in your resection specimens, you'll see one. All right, I'm glad you guys are having fun. Anytime. Yeah, that's the reason we get together and chat, right? Let's show you another case. Oh no, I'm the wrong screen. And this one is 6276. 6276. There we go. We're moving on now. We're going to parotid gland. All right. So all you salivary gland lovers out there, here we go. Nice circumscribed mass, fairly well circumscribed, little irregular. All right. And then here is the salivary gland. That's a parotid mass. It is a parotid. It's a 3 centimeter parotid mass. So let's go and look at this. Okay. Like I said, very well circumscribed, and you can see these pink areas in between, some of them looking a little sort of cystic. Again, I'm not putting ideas into your thoughts, so you develop them as you see the tumor, okay? So this dark blue areas are lymphoid areas. There you can see germinal centers. And then these pink cells here are these guys here. There's these pink cells. Some of them have this pink material in the lumen. Okay, so I'll show you a few more islands so you can, rustle up your own differential and share with the rest of us. Here we go, the same sort of cells, large, abundant, very, very pink, large nuclei, prominent nucleoli, very vesicular chromatin. And some of them having that eosinophilic debris, some having this eosinophilic, what Dr. Baloch calls thyroid-like. Okay, you can see these cells. So let's just move away from those, and there's this intense lymphoid aggregate here. Okay, intense lymphoid aggregate. Let's go to this island here. Same thing here. All right. It's higher power for you. Right, you can see the nuclei. Some fairly distinctive clustering of the chromatin, not too much. That's pretty much the picture. These cystic areas are the same cells, just show you in case you feel that would be helpful. There's the cystic walls, the same cells as those, just a little more cystic. Okay, now that's pretty much it all over this nodule, lymphoid, as well as these pink collections of cells all over that. And then here the same thing. This has just been bisected. Now that I'm looking at it in low power, it's almost sort of like a lobular configuration. I never realized that, but yeah, it does have a lobular like configuration. Interesting. Let's see what you're thinking. Let's go to the chat. Mohammed, looks like Wharton's. Excellent thought, Mohammed. Looks like Wharton's. You mean Wharton's tumor? Tiba Wharton's? Yeah, Wharton. Wharton was Canadian. He described the Wharton starry stain as well. And then the Wharton's tumor. There's one other Wharton I'm forgetting about. There is another. He had three things named after him. Looks like Wharton or lymphoepithelial with oncocytic type. Okay. Tiba, but the architecture confused you. Okay. Architecture confused you because you're thinking Wharton's tumor, the lymphoid aggregate, and then these pink cells. Any other thoughts? Let's go back to the tumor whilst we're waiting for other thoughts. Here's some cystic areas here. Yeah, this has this eosinophilic material, eosinophilic debris. You can go down on high power anyway here just to show you the cytology. Okay. Okay. Now I'm going back to my yes, Solomon. Yes, Tiba. Yes, ciliated. No, Omar. What are you thinking about? What are you thinking about? Are you thinking about metastasis or are you thinking about primary? There's a ciliated HPV related carcinoma, and what ciliated are you thinking, Omar? Query ciliated. It's a good thought. I mean, I'm just curious. I want to know what you're thinking. That's what I want to know. I'm not in a position to read your mind, so let me know, please. By the way, I appreciate you guys, commenting and sharing your thoughts. It really does, because it helps the conversation along. Otherwise, I'll be talking to myself here. Any other thoughts? Any other thoughts? Okay, let me ask you a few pertinent questions, right? What do you think of these pale cells here? Okay, there was that first field I went to. Oh dear. Where is that first field? Right here. Yeah, this is the first field. This had a very nice contrasting. And obviously, I'm not going to give you clues. So you have to figure it out. There's these pale cells. What are these pale cells? Look at these pale cells. It's very deeply pink cells, like I think Mohammed said, oncocytic. I liked that. But what about these pale cells? I don't know if Omar has told me what he was thinking about ciliated oncocytic cystadenoma. Yeah, those have been described, Andy. That I had one last year, late last year. It's in one of my other slides collections. Yan, I think you mean mucoepidermoid, right? Not mucoepithelium, mucoepidermoid. But how do you explain these features, Yan? You say mucoepidermoid carcinoma query, right? Then there's myoepithelial cells. So these are epithelial, clearly epithelial, but they do not show any of the myoepithelial markers. P63 is positive in the pink cells, but that alone does not make it myoepithelial. The calponin and S100 are negative, so the markers for myoepithelial are negative, all right? Lymphoepithelial lesion. Somebody mentioned that earlier on with oncocytic. Yeah, Mohammed, oncocytic epithelium. Was a good thought. And so, yeah, well, thank you, Premila, for bringing that back in. Mohammed, oncocytic mucoepidermoid, but cannot explain the lymphoid. Exactly. So these pale cells are mucin positive, okay? I'm going to give it to you that this is mucoepidermoid. It is mucoepidermoid. Now, you don't get benign mucoepidermoid tumors, so you got mucin there and you got these squamous cells here. And many of these are oncocytic. Let's go back to our screen. Many of these are oncocytic. It's actually difficult to even find squamous cells or the intermediate cells. Remember, you get three types of cells in mucoepidermoid carcinoma. Very hard. But these pale guys here, these are mucin positive. And your questions are very well posed. Cannot explain the lymphoid tissue. But you mentioned Wharton's in the beginning, so this is a Wharton's variant of a mucoepidermoid carcinoma. Wharton-like. Yeah, Wharton-like. Correct, yeah. So it's I know, Albert, too. It is a wow. And so is my second case that I saw. And, like I said, I feel somewhat privileged in having the fish assays that we have with Dr. Zhang, having set these over the last 25 years. So we have mammal too, and that was rearranged here. That was just to, make it good all the way through. So mammal 2 was rearranged, Wharton type mucoepidermoid carcinoma. Now they do have pink cells. And your mention of an oncocytic mucoepidermoid is also a variant. Those don't have the lymphoid aggregate, so those would be more sort of pink cystic structures, and you can find these mucin cells in between. But the big question comes in. You're welcome, Tiva. The big question comes in: how would you distinguish this from Wharton's tumor? How would you distinguish it from a Wharton tumor? Because you did mention Wharton a number of times. That was the initial thought, but the lymphoid aggregates was confusing. The morphology was confusing. There is one way of distinguishing that, and it's quite simple. Remember, Wharton's tumor has this bilayering. Remember that? You get a cuboidal layer and you get a columnar cell. They're all very pink. This lacks that. There's no bilayering here at all. And that's a very useful feature. Next time you look at a Wharton's tumor, look at that bilayering. If there's any absence of the bilayering, then ask yourself, is this a mucoepidermoid carcinoma? All right? Now, you may say, well, okay, that's easy. I can do a mucin stain, but you can get what's known as metaplastic Wharton's tumor. If you stick an FNA needle into a Wharton's tumor, you tend to initiate these metaplastic features, a lot of squamous differentiation, and even mucinous metaplasia. So what you're down to is demonstrating that bilayering. And so you look around very carefully, and when you see that bilayering, then you feel more comfortable with diagnosing your Wharton's tumor. Now, this doesn't have any bilayering anyway. You may argue that, this may look bilaid, but go and look at the Wharton's and see how beautifully composed it is throughout the tumor. All right. Any questions here? Lymphoid structure looks it does, but is that Olga? Let's go and look at the capsule. That's a very good thought, right? Let's look at, is there a capsule here? I don't see a capsule here, right? I don't see a capsule. And there are these sinuses here. You may argue, are those subcapsular sinuses? Yeah, you could argue that. But this we deem to be a primary mucoepidermoid carcinoma. You may argue, well, did this arise in the lymph node? I think when you read the books on this variant, Wharton's variant, they do talk about that as well. You may argue this looks capsule here as well. Yeah, sure. And it's very complex with these intraparotid lymph nodes and tumors that arise from them. Some people believe that the Wharton's tumors arise in those, and they're kind of like entrapped glands within these lymph nodes and then become these Wharton tumors. So you can sort of take your guess in that. I think the jury is still out there, basically. Not too sure, right? But you've seen a nice mucoepidermal, Wharton-like mucoepidermal. We talked briefly about the oncocytic variant that was mentioned. I forgive me, somebody mentioned it. I need to scroll. There's the Muhammad, okay. So that was mentioned. But somebody also mentioned ciliated. I cannot remember who that was. Omar, I think. You do get a ciliated variant of Wharton's as well. That is why, Omar, I was asking you that question. But what do you mean by ciliated? All right. That is exactly why I asked you that question. I wanted you to say you're thinking of a mucoepidermoid. All right. Any other question? Does this variant do better than usual? I mean, not that I know of. Just check the books, okay? to my knowledge, these behave, stage and grade as per usual conventional mucoepidermoids. They grade them uh, briefly. We used to grade them as grade 1, 2, and 3 based on cystic, well differentiated to the more solid, higher grade. There was a nice paper from MSK, Memorial Sloan Kettering, about 3 years ago. You go MSK, mucoepidermoid grading, that paper will come up. And in that, they recommend 2 grades, which makes it much easier for all of us. Low grade, nice cystic, well-formed squamous intermediate mucin cells. High grade, solid mitoses, necrosis, and higher grade atypia. So check that paper out. But to my knowledge, I think these all behave as per grade and stage. I'm not aware of any of these being or doing any better. You're welcome, Omar. I just want to check what's the date for the next meeting. It's always good to keep abreast with the good old diary. Super old school, yeah. February, what we're looking at, March next, right? This is February. So March, I know Ava's got it there, but I just want to concur with Ava as well. Sorry, I'm holding you guys up. I got March 11. March 11, same time, same place. Look forward to all you guys coming on board again. Yeah, I enjoy these sessions with you too. Okay, welcome. Thanks, Ava.